Thank you, Sylvia. Can I confirm that I'm sharing the correct screen and you can see my slides and hear me okay?
Yes.
Thank you. Hello, everyone. Thank you for joining. Excited to have the discussion about this paper. So the focus today is on the CCDD Journal Club topic of translating models into policy. So interested to hear what you think. So a prominent disclaimer, so any findings or opinions that I might happen to express today do not necessarily reflect the official position of my employer, the New York City Department of Health and Mental Hygiene. So today we're focusing on a paper written by these three authors, Jay Varma, Ted Long, and Dave Chokshi, who were executive public health leaders in 2020 and 2021 at the height of the COVID pandemic. So they were in the room when the big decisions that that modeling might inform, they were the ones in the room facilitating those conversations. So it's very interesting to hear what they have to say about their experience. So they recommended several skills based on their experience. Their first skill was the need to be able to translate science effectively. So people at that level, executive public health leaders, have to wear a wide range of hats. They have to manage, be spokespersons, subject matter experts for complex multidisciplinary issues that are constantly evolving. They need to be able to rapidly assess new scientific information and synthesize key points for different audiences. They need to be able to respond to studies that are first reported in the popular press or even in social media before they've even been peer reviewed or before expert consensus has arisen on the issue. And then based on their experiences, they found that they were much more effective in these executive meetings if when they were able to use statements such as, I read the study and this is what I concluded, over my staff or the experts concluded this about the study, so that's what I think. So they really needed to take ownership of the science. So then, given that this is a mathematical modeling club, so that mathematical models were not explicitly addressed in this paper, but I think it's interesting to reflect on each of their recommended skills and how it might apply for mathematical models. And these are the personal reflections. So I'm trying to clearly label when I'm summarizing what the authors said versus trying to expound on it a little bit. So if you think back to the author bios, who are these executive public health leaders? Typically, people who are appointed to that level they're usually medical doctors. They may or may not have had formal training in epidemiology, and they probably have not had formal training in mathematical modeling. So there is a lot of turnover at that level of public health leadership. And there's a lot of competing priorities. So that skill, number one, of being able to translate the science and being a spokesperson and all that, that's like a really complicated skill set. And I posit that it is possibly unrealistic to expect those executive public health leaders to take the time to seek training in mathematical modeling, although I want to make sure everyone here knows that there's these great resources that I mean, maybe we should discuss, like, if they were to seek training, what might that look like? But CSTE has this excellent short course, Infectious Disease Modeling 101 for Public Health. And then there's an excellent Coursera course for infectious disease transmission models for decision makers. So there are like these free resources out there. And then maybe it's a discussion point if it's realistic that the people at that level may have had that training, but the training is available. And then some more reflections are that for certain models to actually be useful, it is people at that level. It's the executive public health leaders who need to be able to discuss the models with elected officials, with politicians who have no training in epidemiology. So this is the CCDD Journal Club, and so I thought it would be appropriate to highlight this model developed by CCDD in February 2020, right at the beginning. So credit to Rebecca Kahn and Mark Lipsitch and Nishant Kishore. So they developed this scenario exploration tool just for, so they had prominent disclaimers. So some scenarios may be unrealistic. It's just for, you need to exercise judgment, but it's for the specific purpose of considering how many cases might currently be circulating in a setting where testing is not yet widespread. So it's not for evaluating impacts of interventions, but it's just when there was, if we can put ourselves in the mindset, will COVID-19 come to New York City? Will it have an impact? That's where we were in February 2020. And the scenario exploration tool was designed to help us consider that probability and to communicate that to decision makers. And so there are these, nice uh, um, toolbars here where there was a lot of uncertainty in these parameters, and you can change to whatever you think is most likely inputs, and then see how that affects the output with many stochastic simulations. But no matter what you do, it seems likely that there will be a large outbreak starting around early March 2020. And indeed, that's what happened. So I was in a meeting in February 2020 when I was attempting to communicate this model, and I used the word stochastic, and it quickly became clear that I had not had the correct training to communicate with people who are executive public health leaders. And so I found it, difficult to, explain how amazing this model was and how useful it would be for decision making to the people who needed it. And so, but eventually, enough people were exposed to this model, and it was used as described in this ProPublica article about, how this model was actually used at the executive leadership level, with some quotes from Mark Lipsitch and others. And so it ended up being a very accurate model, and should have contributed to the decision to impose some non-pharmaceutical interventions. But it really illustrated early on, at least to me personally, that it's really difficult to communicate modeling results with politicians. So that will lead us to our first, I want to plant the seed for the first discussion question later. So I don't know that many of us who are on the call today are consider themselves executive public health leaders or politicians. So assuming none, how do those of us who are not at that position, how can we support that policy making so that mathematical models are useful during pandemics? So they are the science translators, like they are the spokespeople for the public and for the mayor and for your governor. But how do we translate for those science translators? That's what I'd like to think about in the discussion today. The second skill that the authors emphasize is it's a real skill in how you frame, how you move from the evidence to a concrete decision. And so they noted that training and how to critically evaluate scientific evidence can actually handicap executive public health leaders during policy discussions. So we're trained to really focus on uncertainty. And so there's difficulty if you overemphasize the uncertainty. So how do you move from uncertainty to action if you follow your scientific training to be, skeptical, to demand proof for every assertion, to find flaws in every proof? If you are trained to, use cautious language and multiple caveats and pages of footnotes and limitations, how do you actually move to action when you're speaking, to executive decision makers? So in our scientific training, we often have an exclusive focus on assessing the quality of evidence without the additional framework that's necessary for weighing other policymaking considerations. So beyond the science and quality of evidence, what are the benefits, harms, feasibility, acceptability, costs, and alignment with values? So as modelers, should we be engaging with all of these policymaking considerations if we actually want the models to be useful? And then they also observed in their discussions some cognitive bias, where there was an emphasis in estimating harms to one group but not another. So that's a implicit value assessment that they noted. So they gave an example about how skill number 2 relates to debates about protocols for in-person school during the first academic year following the onset of the pandemic, so during 2020-21. And so they were put in this really difficult position of, with limited scientific data, they needed to develop city-level policies related to quarantine, masking, physical distancing, ventilation, and testing. They needed to consider the harms, and also, how do you measure those harms? So I think the folks on this call understand how challenging it can be to measure the harms of, SARS-CoV-2 infection. So, how do you measure infection rates? There's, given it depends on your testing protocol and the specific test sensitivity and specificity and data lags. And then but it's a lot harder than that. So it's not just the infection, but also what are the harms of missing in-person school, of course. So the social harms, the emotional harms, the educational harms, um, the scope of the population considered of who's affected by in-person school is not only those physically present in the school, but also their household contacts. And these other harms are much more difficult to measure and they occur over much, much longer time horizons. So, an exclusive focus on the harm of COVID infection is difficult for policymakers because they have to consider all of these trade-offs. So, so some personal reflections, maybe we can talk about it later. So how do modelers, given that the executive public health leaders are in this difficult position, how do modelers strike the balance between emphasizing concrete actionable recommendations versus all of the scientific uncertainty and caveats and limitations? Knowing that our executive public health decision makers need to be explicit in the costs and benefits, how can modelers be explicit as well to facilitate decision making within whatever ethical framework is being applied in your local context, given and also how that varies by across political contexts. So the decision makers need to balance considerations of protecting those at highest risk of mortality and preserving individual freedom. And those values are given different weights in different political contexts. And so how do we support our science translators, our decision makers in that discussion? And then another thing we might want to talk about are, should moral weights be used to make quantitative comparisons between disparate outcomes? And so it's interesting to think about how, the GiveWell folks, the people who work in effective altruism. So this is a group that very explicitly applies moral weights, just because otherwise the values are there, they're just implicit. So it's interesting to think about how they make those weights explicit and transparent, and then as a way to further the conversation. So I think, is that a useful context for mathematical modelers as well? Lots of questions. The next skill that the authors emphasize is the skill of being able to think big. So they note how the scarcity mindset that many of us are very used to constrains public health. So these decision makers need to be able to think both very narrowly, what do I do now with the resources I have access to, but also expansively, how do I get the resources to do what's right? So, and they also need to know when to spend their political capital to make the big ask. And examples of that the authors gave of a big ask is making, universal testing access, figuring out situations when they wanted to do door-to-door canvassing, being able to draw employees from across the whole of city government in order to staff mass vaccination sites. So these are really intensive asks. And so they needed to think big on certain occasions and get the resources they felt they needed to do what's right, and not be constrained with the resources at hand. So some personal reflections on skill number 3, thinking big. So, if you've ever been asked to make a model by a policymaker, they might request the model under a given set of constraints, right? I think that's a common experience. But the modeling results could help the policymakers consider additional outputs, additional options, and could allow them to advocate for additional resources that they didn't specify in advance. So if you very narrowly follow the constraints that you're given, you could be missing out on helping the policymaker to think big. So the question is, how can modelers be responsive to those constraints that are set by policymakers who might be very, very busy and don't feel like they have time to justify their constraints to you? So you need to be responsive to what they're saying, but you also might be able to help policymakers to think big by adjusting those constraints. And maybe an interesting example to think about is the PEPFAR example. Um, so, so here, maybe I can go to so when this program was established, the President Bush, he didn't want to think like an economist. So that was the type of modeling that was happening. So there's this quote that in government, it's usually, here's how much money we think we can find, figure out what you can do with it. But instead, the policymakers said, that's not what we want. Tell us how much it will cost and we'll figure out if we can pay it or not, but don't start with a cost. So, seeing if you're on the same page about the actual constraints could be an important thing to challenge. And then this ended up being, considered an extremely useful, public health program. And it happened in response to, not being to adjusting the initial constraints and not being like limited to those initial budget. Another skill that authors emphasize is the skill of spending your political capital wisely. In policy debates, executive public health leaders advocated for strict control measures and caution when relaxing measures. And so given the constituents in that room, they ended up being characterized as doctors doom by the leaders who were focused instead on economic, political, or social harms of those interventions. So they were positioning themselves as voices of moderation, and the public health advocates were always doctors doom. Um, so they found what was helpful was building consensus by proactively acknowledging biases and explicitly naming the trade-offs, and that allowed them to preserve the political capital to spend in the circumstances when compromise was not possible. They gave an example of the 2021 summer surge in Delta variant infections, when the policy question at hand is, should we institute requirements for mask wearing or vaccination or both? And they needed to not only consider the effectiveness of those non-pharmaceutical or pharmaceutical interventions, but also what is the acceptability by the businesses who these rules would be imposed on, also the acceptability by the public, and is it feasible given the limits of inspection personnel to inspect, cite, and reinspect tens of thousands of facilities for compliance? If you ask the models, the evidence, the models would indicate that the most effective public health intervention is to require both of those requirements. But given the trade-offs, they chose to invest their political capital in the vaccine mandates while strongly recommending but not requiring mask wearing, because the vaccine mandate was the more durable solution. So some personal reflections would be, how can modelers explicitly name those trade-offs to facilitate those decision makers' discussions of costs and benefits of potential interventions? And I'd love to hear some examples of where you think this has been done well. And also there's the skill of thinking like a lawyer. There is a restricting civil liberties to protect the public's health has a strong legal basis, but there's a need to anticipate lawsuits challenging the necessity, scope, and legality. There's a need to understand legalistic terms like undue burden, arbitrary, and capricious to ensure the policies are going to withstand scrutiny. And then anticipate tensions across different levels of government. They gave an example of a February 2020 executive order by our governor who suspended New York City's traditional legal powers to regulate public health threats, giving broad powers to the governor and the state health commissioner as opposed to the city. It's just anticipating those tensions. The Supreme Court highlighted the challenge of consistency when ruling that New York State's COVID-19 restrictions on capacity at houses of worship can be no stricter than those imposed on commercial settings. So I ask you, to what extent should modelers consider whether the interventions that they're assessing would withstand legal scrutiny? So in wrapping up, the authors provided some training recommendations for future executive public health leaders during pandemics. So they advised that CDC and graduate schools of public health and public policy and management who are producing those leaders should develop training specifically tailored to public health leaders. The tabletop exercises where they build these skills should explore not only how leaders manage technical or logistic challenges, but also rampant misinformation, trade-offs between perceived threats to freedoms and public health actions, and how to deal with lawsuits challenging the public health actions, and develop and test different ways to frame recommendations and explain complex information to different stakeholders. So some personal reflections given that. So substantial exposure to mathematical modeling is not in the core curriculum of the flagship training programs for public health leaders in the US. For example, the Epidemic Intelligence Service or the CSTE LEAD program. There's not a heavy emphasis on modeling. So I wonder what you think about what level of familiarity with mathematical modeling is necessary for our executive public health leaders, and how should they get that familiarity? Are there tabletop exercises in which those leaders can practice using models to realistically inform policymaking? And then given that the focus of these authors was on, during pandemics, so when the temperature is lower, how could we incorporate models into more routine public health practice? And then how do you think the training needs would differ? So that's all. I raised a lot more questions than we actually have time for, but these are the four that I'd encourage you to think about for the breakout session. Thank you so much.